welcome you to the August series from the Nursing Home Social Work webinar. And we are part of the network, and we're offering today's webinar for nursing home social workers, but actually anybody who works in a nursing home who's interested in learning more about psychosocial care, or anybody who's interested in psychosocial issues related to our older population. So welcome to the webinar. Minutes just to talk about our webinar series in general. We have two series that are ongoing. One we call our best practice series, and those are on Tuesdays. They're skill building series. So we social workers, BSW or MSW social workers who are talking about best practice issues in nursing home social work. And also we have something called the Emerging Issues series. Most of those are on Thursdays, and that we look for the best speakers we can find in the country, regardless of their discipline, to bring us up to date on news issues or issues affecting nursing home practice. So just wanted to let you know, right now, both of those series are free, thanks to a grant from the Retirement Research Foundation. You are welcome to join the live sessions like you have today. Welcome, everybody. And I just wanted to let you know that most of the people who've joined, the audience is listening through their computer, but we still want to hear from you. And so please use the question and answer box to type in a question that you have for the presenters, and then I'll be monitoring that, and I'll either save your question for until or interrupt the speaker. If any logistical problems with hearing me or with seeing things, then put that kind of a message in the chat box. And checking the chat box and the Q box throughout the session. Recordings, all of our webinars we are recording, and the recordings are available usually within 1 day of the session. So we hope to have these up by noon tomorrow, Friday. And have our last webinars, recordings of those also loaded. And so I hope you enjoy those. We're going to do a quick welcome and introduction of our topic and our speakers. And then our speakers are going to present the information that they've prepared for you today. And then at the end, we'll have the question and answers where people who typed in questions during the session will go to those. If you make a note of what the slide number is for your question, that'll help the speakers too if it's about a specific slide. So at the top of the hour, our speakers will wind up their next 15 minutes on your questions or your comments if you have any. I'd like to acknowledge the financial support from the Retirement Research Foundation, and I'd like to also thank the National Planning Committee for working on this project. And then also there's a collection of nursing home social service staff members right here in the Iowa City area who are working with us here at the University of Iowa to make sure that these webinars are really useful and to folks. Conley was going to be introducing our speakers. He's the co-principal investigator for the webinar, but he was not able to join us today. So I do want to acknowledge his expertise and assistance, and we hope to hear from him on the next webinar. All right, at this point, I'd like to introduce the topic for today. That's the bridge model and transitional care from nursing homes, communities, and hospitals, a social work approach. We have two wonderful speakers. We have Debra Markovitz. She's CSW, a licensed clinical social worker at Rush Health and Aging in Chicago. She provides transitional care services as a bridge care coordinator, and she specializes in working with older adults and their caregivers. She's got a lot of clinical expertise, as you can see on the slide, and she also does other coordination and other training. So we'll be hearing from her. And our second speaker, also a social worker, Ilana Shure, is the program manager of the Aging Resource Center, also in Chicago, which is a transitional care program based on-site at the Adventist LaGrange Memorial Hospital. Ilana is involved with supervising MSW students, and she has an expertise also in working with older adults and their family members. And she's been working on this transition program as well. I go over these learning objectives, and then we'll have Debbie Ilana take over the rest of the presentation. So what we're going to be going over today are explaining the principles that underpin the Bridge program. We're going to be learning about the processes and the skill sets needed for the Bridge program, describing the role of social work in transition care, and then understanding how processes and collaborations are actualized through case examples. So if you'd like to advance to slide 5, sure. Take it there, that'd be great.
So we just want to thank you very much for the opportunity to present today. We're excited to share how the Bridge model assists older adults and their families with the transitional care process from hospital, short-term rehab to home. And we also hope to hear from you listening in and learn from your experiences as we talk, and then at the end when we have questions and discussion. So you can see on this slide the agenda, what our goals to tackle during this presentation. So we're going to spend some time talking about social work approach to transitional care, why social work. We're going to talk about partnerships and collaborations, which are really a foundational imperative for the Bridge model. We'll talk about the model, the nuts and bolts of the process of this transitional care approach. We'll talk about the Bridge model in its context. We're from different sites, so we'll talk a little bit about the way we're able to implement Bridge coming from different sites with different venues that we do this model. We'll talk about SNF partnerships in the process, and then we'll have a case example and time for questions and discussion. So I'm going to take some time describing the landscape or the big picture for the Bridge model. Social work approach to transitional care, currently implemented at over 20 sites across the country. It's been active as a transitional care model during its pilot stages in rural, urban, and suburban locations. So first, transitional care is simply defined as the movement from setting to setting, so hospital to SNF, for example, or in settings, acute to acute rehab, for example. What is these movements is the need for coordinated care and good communication. It's often fragmented, so care is needed as a way to mitigate fragmentation, service duplication, and costs, and reduce adverse events from setting to setting. We also talk about people falling through the cracks due to difficulty with communication. So between providers is often limited. There's a lack of technology to easily facilitate communication. And communication, we all know, takes time. And sometimes when we're working so hard and focused on our process within our discipline, it's really hard sometimes to take a step back and focus on working together, communicating across settings as well. Working with a vulnerable population. Older adults are more likely to have multiple chronic conditions. They're often isolated, have mental or cognitive needs, multiple medications, mobility, transportation. I know here I'm preaching to the choir, but we're focused with Bridge as a social work approach to helping older adults and their families transition safely home. Results, the focus on a biopsychosocial perspective is really necessary. Bio, or the medical piece, is imperative to address the health issues that are impacting hospital readmissions and impacting the life, the ability for older adults to live independently in the community as best as possible. And, we have to focus on these social determinants of health to make sure that we're really looking at the big picture of how we can help stabilize people in the community and assist with this transition all the way home. And echoing our focus on needing to pay close attention to those social determinants, literature highlighting the importance of looking at people holistically and looking at the biopsychosocial perspective to ensure successful transition. So recently, researchers out of Northwestern published in the Journal of General Internal Medicine showing that people, regardless of cognitive status, those who even have memory loss to begin with, when in the hospital, decline. They're experiencing great difficulty making decisions, and they get back to their regular cognitive level about 30 days after their hospital experience. And so we not only recognize this as being difficult in the hospital, but also when they go into rehab, the effect is still there. And it's important to keep in mind when we're working with people who are having trouble making decisions, and why is that? It's a crisis, but they're finding that there's a cognitive decline that can be measured during this transition. Published in Health and Social Work that 40 to 50% of readmissions are tied to psychosocial problems and lack of community resources. Put example to this is somebody who's struggling with falls and coming into the hospital readmitting for falls. Definitely something medically occurring for this person, resulting in them having trouble with balance. You think of different reasons for psychosocial related problems contributing to this. For example, medication management might be causing a fall risk or falls. And the difficulty with medication management, if we really look closely and investigate, could be due to financial issues and difficulty affording medication. So it's while we're focused on the health realm, it's, as we all know, as social workers, we also need to look holistically. And so with Bridge, our real aim was to make sure that there's a transitional care approach, not applicable across settings and with geographic diversity, but recognizes that we need people involved with the transitional care process who can focus on the social determinants as well as the medical piece. So this next slide, we're going to focus on kind of a big picture of the Bridge approach. So the Bridge model, it operates systemically to best navigate and problem solve patient needs. It's looking on the physical body of the client and at the many layers of systems that impact the client. So this from a social context, we're talking about the microsystem, family, friends, caregivers, neighborhood, expo systems that indirectly impact the patient, the older adults. For example, if a caregiver is having a difficult time at work, they may transfer this frustration to the older adults. Where all the impact the macro system has the client transitioning, which is a context around the older adult. For example, socioeconomic issues, education, attitudes. Bridge seeks to create culture change. So we're talking about this chrono system here, speaking social-workery, and by encouraging partnerships and advocating for system changes. About this as we continue, but that's the main piece of Bridge application of our model. Strengths focused and looks at patients holistically. Strengths-based meaning it promotes self-efficacy and empowerment for the person, the individual experiencing the transition. It's a medical approach to what went wrong, but it's the strength capacities of a person to determine their recovery. And everybody listening in can think of many examples where this really is true. Person-centered capitalizes on what we call the servable moment. They may not be ready to accept assistance and the help that they need for in the hospital. They may be more ready later on during their skilled nursing facility stay to think more concretely about accepting help. It may also be after they return home during the bridge model when we check in with them once they discharge. They may be more willing to accept help at that point. And so it's person-centered, meaning we're not forcing somebody to accept or support at a particular time because that's protocol, but working with the person and waiting for them to feel ready to accept the support that could help them. We're focusing on making sure that individual is the one who feels empowered to accept assistance and make a change. And we have patient activation all the time. So that servable moment is really that point in time where the patient is fully activated. And partnerships and collaborations are imperative to transitional care work. Social workers are adept at developing and managing partnerships. It's part of school training. And collaboration is a core activity. Competency in social, we are trained to think systemically. We're always thinking about those different levels of the system that impact our clients. All right, we can move on to the next slide.
This is Debbie speaking. I'm going to talk about partnerships and collaboration. I'm going to try to give you a few conceptual definitions of what those words mean and kind of how they play out and different ways of looking at what those ideas mean. You know, there's a continuum of collaboration, and then also look at the value of that and what we gain from that, and then just some kind of real tips or how-tos that Ilana and I have learned from our experiences in developing these partnerships and collaborations. To begin with, that the idea of collaboration and partnership are really inseparable. They have to be thought of in tandem. Defined as the formal interagency or institutional arrangements in planning, delivering, or monitoring of services. A collaboration is the collection of knowledge, skills, values, and motives of practitioners to translate the following into effective practice. So the partnerships as the relationships I have with the vendors or agencies I'm working with, and really the processes we've worked out. And the collaboration really comes down to what are the ideas that we share in common. What's the mission that we're all in for? Do we both agree working together and moving to a better place? Those two things kind of counteract each other and are inseparable. A quote I really love by Whittington really elaborates how collaboration looks in action. And it's descriptive. So it starts out by saying collaboration in action can be a decision. It may be focused on the nature of social care problem to determine a course of action to secure service for someone in need or to reestablish help broken down. It's a collective of factors that enter the exchange. That is the views of service providers and carers, service policies and structure, interagency agreements, professional cultures and methodologies, status, budget and care resources, time, and personal style. And I think what Ilana and I have learned, and those who I'm sure working with other providers can relate, that there are many, many, many factors that have to take consideration in developing these relationships, and can be something as simple as some not feeling like they have the time to meet with you and sit down and talk about developing a partnership and a process, or our agency on a higher level isn't really ready for that kind of culture change, because we are asking people to work a little differently, to think a little differently, and to trusting relationship, which it really takes to get to a point of collaboration, of real collaboration. So there's many factors tied to collaboration. Provides a continuum, and it just kind of gives you an opportunity to evaluate your current level of collaboration with other agencies or people, and to kind of clarify the level of collaboration needed to meet the objectives of our organization. Or it could be just something in your department and working with other departments within your organization. So if you're working in a nursing home and maybe there's with laundry, you may not need to go all the way to the level of integration, but it could be just a level of communication where you have frequent contacts. It is some formal arrangement for working together, but it may not need to be as highly integrated. Maybe there's processes for communicating that are very specific. Sometimes it doesn't have to be super elaborate. There needs to be sort of an understanding that you are in isolation and being encounter and try to a deeper level, so that there is trust and respect for the objectives that everyone needs to gain for the benefit of the client. This one talks about the of our partnerships. We have worked extensively to our walls. So placed in a hospital setting. And I know that when people leave here, they have got to have solid care in the community. Or, a person is leaving a short-term rehab, you want to feel like when they go home that there's going to be providers in place that you know and you can count on they're going to be there. So what we simply learned is that patients do not live in the hospital or short-term rehab facilities. They live in homes, communities, the care that is established in the hospital is only as good as the receivers and the provider's ability to actualize it. So one setting support the other or not. Be a recognition that some services are interdependent and that actually one part of the system has an obvious effect on another. So what we do here in the hospital needs to affect what happens when people leave, or when people leave the nursing home. They've made progress with your therapists and social workers, and you don't want to lose that progress and that flow. So you will, you're passing them off to home care providers, family members, neighbors, that are going to be there, Department on Aging, anyone that's vital to their care plan. One party feeds the other, and in my mind, they are inseparable. Partnerships are a pre-established collaborative processes. They have a great impact on patient outcomes, and that reiterates what I was just saying. Meaningful partnerships allow timely data transfer, expedite community service provision, and for problem solving. So when I give the case example at the end, you'll get to see how the partnership really helped information get transferred to where it really needed to be, and how we got to a deeper level of understanding about that situation. It was very complicated, and it really helps with problem solving. So the next slide is really an example of the to be there, who are kind of our vital players in facing the clients. Obviously, pharmacy, the aging network, the skilled nursing facilities, the caregivers, the family, the community-based agencies, home health, the primary care, the specialty doctors, all very important. And the care coordinators, which are the clinicians in the bridge program, that's the people actually providing the clinical intervention to the patients, we're skilled and trained at facilitating and maintaining these relationships. And as many other social workers like yourselves, we are really trying to navigate community resources and make sure patients can access their medical plan of care. Because it's a picture of everything at the elephant, the elephant in the room, and everybody looking at different parts, but everybody's looking at those parts so closely, but there's distance, and there's no interaction among these parts, and the people looking at the wall, to the rope, to the tree, and the snake. But all these people have intentions, they get taken off the blinders to talk amongst each other about what these different parts mean. And I think that traditionally it is easy to be focused on your own discipline or vision, but with transitional care work, we are really trying to break down the silos. And again, this recognition that services are truly interdependent, and action and one of the system has an effect on the other. So this is the idea. There are some tips that Ilana and I had put together, the difference between cultures. That's one of those things that's often felt and heard. It can take a while to understand and get to that, what's going on, why maybe something's not working. People differing cultural, political, politics, budgets, personalities, they drive the way people behave and think. Those things have to be considered. Second, come from different perspectives and different languages. And this is really true as you are all social workers working in a medical setting, that we can see things differently. We may define MI as mental illness, but a nurse or doctor may look at MI and think mental infarction. And an educator might look at that and think, oh, motivational interviewing. So you need to be careful. Take the time to really talk with each other and ask each other what those experiences meant to them, because it just makes it very different. Concerns, try to just be as in troubleshooting and working together. It's a process of developing mutual respect, understanding each other, and it really takes time and commitment to understanding and find out what can one provider really do, and maybe there's something going on in their agency. Like, we've been working with one home health care agency that we've had challenges in getting social work in home, and that had been very frustrating to us. So finally, look, we really value your service, and we need to know that if you're going to provide social work services in the home, as they are in your home health care service, what's going on. And it turned out they were having some and they're having some financial problems. So it's just been for them to provide that service. So we have that and try to adapt to that and adjust. Requires skill and clear intentions. Parts do not happen accidentally. It always requires structural, institutional, and individual action. It requires drive, vision, and ability to find like-minded people that are willing and able to make this investment in partnering. It is an investment. You've got to give some to get some, and it does take time and effort. But at the end, you've got to find people that agree that this will benefit and it will have a part in that person's care. And I would say, too, take to really acknowledge successes and challenges. It's something as simple as a phone call to acknowledging that they did something that really made a difference in a patient's plan of care. And that thank you can go a long way. Next, we're on and talk about the bridge model, how that works, who serves, and kind of what intervention is focused on. Okay, so the bridge it kind of works in 3 phases. You'll see later that the nursing home model for bridge has a much more elaborate process. We'll go through that. It starts basically before the patient leaves the hospital. There's a referral obtained to us. We do an assessment and look at, why they came in the hospital, what some of the risk factors. We can talk to the doctors, talk to the inpatient social workers, try an idea of what the person post-discharge. The next part, which is do a telephonic call 48 hours after discharge, and we have an idea in our mind we want to focus the call in on is that maybe were family dynamics that were impeding, a patient or caregiver stress and the caregiver needs support. It's simply that they need a lot of medical equipment, a wheelchair, a hospital bed, infusions, or they're having an ostomy. And so these things, they're, overruled and now have a hospital bed in their living room. How are they coping with all that? They're connecting to providers. Home is really common, mentioned a lot. And the CCUs, the Department on Aging, if there's health needs, reaching out to those mental health providers. There is, like I said, equipment, we're checking back with them. And of course, we're always looking at what the support is and what are the needs there and how can we assist. So we do 48-hour post-discharge telephone call. We assess, we intervene. And it can take anywhere from a day to 2 or 3 weeks, depending on the complexity of the situation. The third stage of the process involves a 30-day follow-up call. So this is made by someone other than the bridge care coordinator. And they are doing a little data collection, but they're also trying to confirm that the structures maintain that patient and the family for the long term are intact and in place. Did the get, our homemaker services getting in? Are they okay with those services? Is it working okay? They getting to their primary care physician or any specialist? How are they doing? And so it's nice to know someone else is checking in with them at the 30-day point. And if there are other issues that come up, then they will loop back to the bridge care coordinator with concerns, and we will follow up. The end goals, increased readmissions. I know everyone in the world is working in healthcare settings is hearing about that. There is a huge amount of pressure to reduce readmissions and adverse events that happen once people get home. With mortality, ensure that the physician follow-up is in place, and if not, why, and things can we put in place? We want to increase the uptake of medications and the discharge plan. So do they get everything? Do they have questions? Do they have any concerns? Are they taking them? Are there effects? What are the barriers there? Because medications are very, very delicate. And most older adults are going out on a very large number of medications. So we intervene on that a lot. And the other thing, I think we've effective with a bridge intervention is to find a quick mechanism in reaching caregivers. We're very stressed, and they often don't have time to get out and go to support groups. They are juggling so much. But the phone has been a very immediate way to talk to them, give support. Seem to respond really well to that. So that's really effective. And then we, of course, want to decrease the patient's stress. And the patients can be very overwhelmed when they get home from the hospital. So we can make sure their plan of care is in place, and then as well provide some support. And if they need linkage to other services, our recommendation is people must have the three variables that they are 60 or plus, one a condition, and then the previous hospitalization within 6 months. In addition to those three variables, have at least one of the variables. They must be discharged with home health, live alone, or to a skilled nursing facility. Current is trying to expand in realistic pressures, be flexible, and try to the needs of as many patients that we can.
Yeah, and so too, for example, at some sites, for example, at Rush University Medical Center, it's a huge hospital and we have limited staff there. So we added criteria to criteria. So for example, at Rush, somebody who's eligible for bridge must also have, I believe it's 7 or more medications.
Mm-hmm.
At my site, which is a suburban site, my site, which is suburban and much smaller hospital, we see especially the frail older couples, so those partners who are frail and in need. So we do not limit people based on whether or not they live alone. So we keep it currently somewhat flexible, so which site is replicating, they're addressing the most vulnerable older adult population.
Okay. The intervention focus tries to ensure that patients and caregivers understand and can access the discharge plan of care. So do they really do they have information for their specialist? Do they know where they're going? Do they have transportation to it? To connect patients to their healthcare providers and community-based services and facilitate communication. We spend a lot of time to ensure that that the Department on Aging is called to be in, that they've got a referral, and that referral is in process. Chicago is the Department on Aging here is huge, and I think they very hard, but sometimes referrals do get lost, so we check on those things. We want to provide support, information, and resources to patients and caregivers. So one is just diagnosed with a seizure disorder. Are they aware of the seizure foundation? Or if they're a struggling caregiver for a person with Alzheimer's, try to know that the Alzheimer's Association has a number 24/7 they can call. So we try to educate and be empathic to the, and sometimes the burden that they're carrying, as well as to celebrate the that many people make in adjusting. And we try to test for safety and stability of a home situation. We do actually a lot of crisis management in these calls. Some, saying has been advised, and families, this is very difficult for them. They will not accept that, so they go home, and some of the caregiver is like, whoa, wait a minute, my 60 pounds. I didn't realize I couldn't help in bed, but I cannot do that. So all of a sudden, people are now faced with the reality of a situation. And what Ilana was talking earlier about, that servable moment, and intervening when people get home, you can really capture people in time of need, and we've got to act quickly and be as problem-solving and supportive as we can. Also try to track systemic problems for corrective action or change. So social workers trying to work in our own silo, we want to affect culture change. We want to try to affect policy change. So we try to keep track of where are the glitches in the system. How can we shake that up a little bit? Is there somebody higher up in the Department on Aging that we can reach out to? Or if it's an organizational problem, can we go to someone else? We are trying to think about a larger picture, and really at the end of the day, we can make things better if we do go that route. We do feed information back into the hospital, the community organization, to guide future care. So if you know, for example, that has decided to change their primary care physician, as transitional care within the hospital, I can go into the medical record and note that. So in the future, should the patient come back, people can go into the medical record and see that. Hopefully that will, the care better, right? Now, Lynette is going to talk a little bit more about the which we work in. And
yeah, we're going to get a little bit more specific about our own experiences implementing Bridge at our site. To kick it off, I'll talk a little bit about the perspective I'm coming from. I work at Aging Care Connections, which is a care coordination unit outside of Chicago in the suburbs, the southwest suburbs. We partner with the hospital and 4 skilled nursing facilities in our area to provide the Bridge model. So what I'm about is being from Aging Care Connections, which is a care coordination unit. I'm part of the Aging Network through the agency I'm employed, and working with Bridge in that manner. So for those of you who same page, I'm just going to talk a little bit about the Aging Network. It's a major component that Bridge leverages, and seeing critical safety net, a great based resource, and it's an established funded infrastructure that already works to meet the needs of older adults in the community. Bridge does not seek to duplicate any existing systems of care, whether it's models of care, family care work, or community network like the Aging Network. Instead, putting together the social work care coordinator, knows it all those systems, and the commission works to connect these existing works and the existing social and medical models of care. So while I'm employed by the CCU, I have great access to the Aging Network. Regardless, for example, Debbie, who works in the hospital, also has great access to the Aging Network for partnerships and collaboration. To talk a little bit more specifically about this Aging Network as a resource in transitional care and how helpful it is to connect our clients transitioning home with it, I'm going to little bit about what CCUs, care coordination units, or what they're recognized as throughout other states of Illinois as area agencies on aging. So in Illinois, you'll see CCU or care coordination unit on this slide pretend as a area agency on aging. And what the Aging Network has for these clients transitioning home are basically three different areas of assistance. And so the first one at the top is the Medicaid waiver program. This is a program funded through federal and state funding and provides people transitioning home with adult daycare, emergency home response systems like those life alert buttons, and home services. And then we use this a lot. People who are discharging home from skilled nursing facilities who could use home care assistance or some adult day services, we connect them directly to the Aging Network and a system to start working with them and connecting them to these services. So we're duplicating efforts, but what we're doing is coordinating together to make sure that people have access to this network that's in place across the country. Opportunity also, which is federal, is through the Older Americans Act services. So the services are home-delivered meals, caregiver support services, transition, information, and assistance. Meeting with somebody in the skilled nursing facility was thinking about discharging home, we would talk to them about considering meals while they're finishing up their rehabs and is unable to drive, for example. Talking a lot with the caregivers when we're working with people who are still recovering in the nursing home. And so often we're doing, as Debbie has mentioned, a lot of crisis work, a lot of connection to caregivers to begin to get comfortable with the idea of safe support group. Transportation, especially when we are thinking about how we're going to help our clients get to their physician follow-up appointments. And assistance, this becomes really important when we're thinking about bringing the Aging Network to folks who are transitioning home from the nursing home for rehab or from the hospital. Most of the people I see aren't considering themselves as old who could qualify for things like meals. Usually this crisis, this hospitalization, and this recovery period where people start to think about their abilities and ways that they can might need to accommodate their needs. But your typical 60-year-old plus hospitalization isn't usually looking into the Aging Network and what services they might be entitled to. And so this is a real opportunity during transitional care to inform individuals of what services are and what they have to offer to them and that they're entitled to them based on their age for the most part. There's one third opportunity for the Aging Network, which are in volunteer services. So AAAs in other states or care coordination units in Illinois all provide, which are typically grant-funded programs to meet the community-specific needs. So these include unique counseling programs, ethnic resources, community-specific, and local. On the Aging Network as the bridge model, because again, we don't want to duplicate out there, but want to capitalize on this great potential for a partnership that benefits the folks we're trying to keep safe at home. And lastly, one other component is the Aging Resource Center, which is part of the asset to the bridge model. Aging Resource Center is an on-site location for the bridge program. The establishment of this ARC, or Aging Resource Center, symbolizes the commitment of both partners to sustaining the bridge. Currently, we have them in the hospitals, but considering and exploring this as a great resource for skilled nursing facilities to access to information, support, and resources for their patients, residents, as well as their caregivers and family members. If a physical office space for the bridge care coordinators to receive referrals and access records and work with the interdisciplinary team. It provides a library of resources for clients and caregivers, health literature, disease-specific information, caregiver support groups, and basically just access to the support. Space to collaborate with a team or have family meetings, and for the bridge care coordinator to meet with clients and their families to discuss sources in a quieter space, away from the chaos of those rooms. Is a great opportunity not only to have the bridge on site, but to have something physically, or something that's very tangible and present, to solidify that partnership.
You have about 12 minutes left. So if there's anything that you want to skip to make sure we get covered, if there are any questions, then we can go back and pick some of the information you had to speed through. Thanks.
Sure. This is Debbie. I can quickly go through the next few slides. I really like to get to the case examples. So, the setting that I'm located in at Rush University Medical Center is a very large urban hospital, 676 beds. We're in a diverse neighborhood. We have 2 resource centers, the Ann Byron Wadd Resource Center, which focuses on older adults, and the Tower Resource Center, which is for all ages, actually. We are trying to be very culturally competent, making sure our interventions, as there's other bridge sites, to be culturally, racially, and ethnically the patient's situation and their background. Talk about the structure of the SNF partnerships. Rush, we are partnering with Warren Barr Pavilion in Chicago. That's a home not about 10 minutes east of us. We've been doing this since 2012, and we've had about 34 referrals working with that site since May of 2012.
At Aging Care Connections, we've partnered with these 4 skilled nursing facilities in our area. We've started since 2008 to address the needs of our community. So we work with The Grove, Meadowbrook Manor, Lexington of LaGrange, and Plymouth Place. And we'll just move along. Should we jump into the case example?
Yeah, we could jump into the case example. I will break it down. I will break those steps down. Case example. So it starts kind of actually before the patient discharges from the hospital. The liaison assesses the patient and alerts the bridge care coordinator of the discharge and that they've accepted the patient. I can, in the model at Rush, I will then go into the medical record and do sort of a cursory assessment, noting what some of the risk factors are. The case example, I'm going to get some of the things I noted were falls, pain, and there's blind, caregiver issues. But also noted the patient had some real strengths. She's articulate. She knew what she wanted, and she had the support of the son, and she was very well connected to her providers. From there, then, the patient does leave the hospital and discharges to the nursing home. At that point, what I do is I communicate to the nursing home, I check the background, why they came in, give a little assessment that I can gather from the staff and the medical record. In this case example, this is an 81-year-old African-American woman from the west side of Chicago. She lives with her son, who's the primary caregiver in a home. She came status post a fall, had a right eye globe, and the was really due because she was hyperkalemic. She's pre-medically complicated with diabetes, CAD, renal issues. She's had a history of a stroke. There's a lot of ADL, IDL concerns. She really non-ambulatory. There was pain, anxiety, obesity. Only at the time of the hospitalization was a walker. Again, strengths that she had a long-time PCP of 20 years and strengths in the healthcare system. She's very articulate, and there was no history of home health care or homemaker services noted in the chart. There's an assessment done at the nursing home. So the nursing home transitional care team gave me some feedback about how she was adjusting to the placement there. They had a cardiac care program, and she was put in that. I did give the son a call to check him and see how he was doing, kind of how, see what his perception was of the situation, and he was very committed, very to get her out of there and get her home. He acknowledged some caregiving challenges. He was, pretty open to some assistance from me. I had some more history of the situation. She had leg pain due to motor vehicle accident from years ago, and the blindness was an addition. So then at Rush, we have weekly phone calls with the transitional care team at the nursing home. And at this point, this includes a social worker and the speech therapist. So the social worker is giving the social components, and the speech therapist, obviously, the perspective. And this is kind of, by the time of discharge, what we had learned from her. Therapy, there was noted reluctance, still really not progressing very much, not very ambulatory, anxiety, but she did respond well to some coaxing and pain medications. At the nursing home did not feel the patient was very realistic about giving for the situation. They described him as very, very thin and short, and she's pretty large and heavy. So they weren't really sure about it. They did referral for homemaker services and Meals on Wheels. They did agree, the patient did agree to use one of the home health care providers that affiliated with the Bridge program. So the home health liaison met with them before discharge. PTOT social work and home health aid were ordered. LIME put in place, Hoyer hospital bed, commode, and wheelchair. Patient had medications, and with care needs, we were really concerned about the son being able to manage them. So we did suggest that they try a home delivery service, and they were agreeable to that, and that's a wonderful patient follow-up with a PCP. They recommended a home physician, but the patient did not want that. Patient was really concerning. There are certainly mental health needs, a lot of frustration the patient's experiencing. We recommend some home psychotherapy services, but the patient was really not, willing to try that. So I made the 2-day post-SNF assessment. I spoke with the son because the home health care and the DME was in place. So I'm comfortable with the medication delivery and managing the medications. Patients still problematic to the follow-up appointments. They were really undecided about homemaker services and Meals on Wheels. Stress with him, and he mentioned, feeling overwhelmed with it. He had support, but he was very, very dedicated to her. Seemed, really accepting support. The son seemed very tight, very enmeshed. Sort of seemed to me like there was some power dynamic, the patient seemed to have over him. I tried to encourage him to take care of himself, get the support and family. Try slowly so that I didn't overwhelm them, and to try to develop some rapport with them. Now, at the same time, I had partnered with the home health care social worker who had also come in. So the feedback was that the Department of Aging hadn't been contact from them yet. He had also was concerned about the caregiver situation, and the mobility and, medical appointments were, concerning. The home health care social worker did feel that Sun really did do a good job of managing patient care needs. So then I checked with the local CCU to check on the homemaker referral. They did have it, but noted that it was declined. So I talked with the Sun and patient about it, but they really were not welcome to we're not wanting this. They are very independent. My next task is to really try to coordinate the transportation, logistics, follow-up appointments. The Sun and the patient were really insisting she needed a stretcher, and I was very concerned about the feasibility of that. I was really even concerned, could she physically tolerate the movement and laying on a stretcher for several hours? And also, could the outpatient offices actually accommodate, have space for that? So I was seeking the perspectives of these other disciplines, and the PCP, they have space, but we cannot take her off the stretcher. So they were not, willing to do that. They recommended a home physician or, a physician to come to the home. The office just said no. There was like the size of a postage stamp. We're not going to, that wasn't work. The doctor also said that it really wasn't urgent, so to wait. Read this back to the patient who I spoke directly to about this. She was very upset about this. She said that she just cannot sit up for a long time or stand. She was still to coming to the home. I guess she had tried that before. It was a negative experience. I tried to get her, to work with her, reconsider that. So another party that I reached out to try to have more understanding was the home health physical therapist. He described her situation, but I also learned that he had a very good relationship with her, and he was willing to talk with her about it. And lo and behold, he was the person that had the magic touch to convince the patient to let a home health doctor in. So I made the referral to the home physician, and it worked. So that was a great accomplishment. It was a lot of work. 2 weeks. This came on for a few weeks, but the home health social worker and I continued to stay in communication. Contacted the son. Now at this point he's getting tired, and he said, I would really like the homemaker, but she does not. He was honest and reflective about his limitations, and I'd encourage him to set limits with her. I think this is really hard for him, and he was much vacillating. He actually said, pretend like my needs don't exist, like he didn't care. And I talked with him about that, and understand like what was that power dynamic. But the son was really not yet ready for change when you think about interviewing and trying to get people to change. He was contemplating it, but he was not yet ready to go. Information about caregiver supportions, and welcomed him to call me back. Well, I fed all this information back to the nursing home transitional care team. So, because they really, I know you guys really do care and wonder what happens once you're patient. So, a 30-day post-discharge assessment was made by my colleague, and she spoke with the son's situation. Seemed stable, still challenging. Healthcare was still in there, although less frequently. And the son, at this, no further questions or concerns. For me, the takeaway was that there were challenging family system dynamics, ethical dilemmas, safety concerns, and I couldn't have moved the situation further. The use of the partnerships and getting the understanding of the people in the home, people that could see what was going on and pre-existing relationships. So that those partnerships were really, really imperative. I couldn't have small gains I could make without their perspective, and things that I was not going to influence, but we did try to and support. So I'll open this up and appreciate everyone listening, and would really love to hear some feedback or questions, reflections on this.
If you have any questions, those of you in the audience, please feel free to put it in the chat box or the question and answer box. I'll check both of them, and while we're waiting for people to type things in, we'll mention just a few things myself. First of all, as going through the case example, I was really the finesse in which you use to both assess the situation and then how you approach people with such care and such consideration, recognizing that you want to be building a relationship and that it's going to be the relationship that allows the person to accept the care. And I just really wanted to compliment you on bringing that out, and also that kind of shows that use a lot of the skills that we're trying to be teaching our social work students. So it was wonderful.
Thank you. It takes, that old adage of starting where the client is at. We know we're not going to make any changes. We're never going to make any inroads if we aren't really to where people are. So it's sometimes a matter of planting seeds. In some ways, I wish I could have done more. In this case example, there are a lot of systemic things going on there, I think, that I'm privy to. So, it was just a matter of, letting this, I'm concerned, please trust me, and here's some information. Should you like it in the future?
Question that came in a little bit here. It says, in the case mentioned, precedence, the son or the mother's needs. I thought we were supposed to think of the mother's needs first. That's the question.
That's a great question, because the patient says everything, and was sort of protective of her. So intervention's telephonic. So, for example, he'd always be answering the calls. It took me some prying and something to actually let me talk to him on the phone. It finally there was a point where she wanted something, and then she was sort of willing to talk to me. I will, if concerned, ask the caregivers to the patient. The son was pretty protective, but we try to start with the patient. It's a little difficult with the phone who gets it, and it is true that really the son was kind of identified patient because of the nature of the intervention. So I with that and tried to work with him around that and provide support. The patient, what we couldn't do. So she was sort of working on the periphery, and not all cases are that indirect, where you're not working with the directly. But this is an example where there was a lot of caregiver support needed, and I think that was helpful to him.
Yeah, what's interesting too is that over about of the cases with whom we work, we're working with the caregivers as well. So our focus is on the health and the well-being of the client, older adult who is that patient. We really focus on that holistic look at the families' interplay with people's well-being, and so about half the time, if not more, I haven't seen data lately, but the last data I saw was about half the time we're working with caregivers in addition to the patient.
We have a question that has come in. The question says, obviously collaboration is key here, but do you run into conflict with the home health social workers as if you are doing their job, unquote?
Sure. A lot of questions we get when we present to audiences ask, aren't we stepping on so-and-so's toes, be it the hospital discharge planner, the nursing home discharge planner, home health. And just going back to our model, it's so much about partnering, collaborating, and avoiding duplication. So we're really working with these folks with the same goal. And Debbie, you talked a lot at the beginning about the part is who you work with, but the collaboration is working towards those same shared goals. And so to avoid, stepping on someone's toes or doing somebody else's job, what we're doing is work together within the context of our roles to make sure that person doesn't fall through the cracks. A key place on interdisciplinary teams at the hospital during that discharge phase, and disciplinary teams at the nursing homes during that discharge phase, and also working very closely with home health, with a primary care physician, and care providers is so important.
It really speaks to having an understanding of what the model is, and having understanding that you're not trying to. I think a lot of providers can feel very threatened by this, so we do spend a lot of time developing those relationships and trying to ensure an understanding of what we're doing. But without that process set up before, people feel threatened. But because we have, as an example, I know that social worker very well, and he gets the model, he buys into it, he appreciates it. We can together kind of divide and conquer the tasks, and so it's actually very efficient. And different perspectives are very complementary to each other, because he can see things I can't, and I can see other things that he can't.
We have been. Thank you for that response. This question reads, are there other disciplines or staff members involved in the bridge model, or is it exclusively social work?
There are a lot of other disciplines. They're trying to work with all the providers that support an older adult that has a chronic condition. So we work with, like I mentioned, a home delivery pharmacy service. We have a vendor that we've been working together with to establish some partnerships and protocols. We have a community-based mental health provider that works with Medicare and will go into the home. So we've worked with her.
Even obscure like pet care.
Yeah.
Organizations in our community who could provide some pet care assistance while it's in recovery.
Transportation vendors we've tried to kind of partner with, because that's really key. So,
in terms of your staff, are you social work staffed, or do you have other disciplines on your staff?
Social work model. So we are social workers, all of us on staff.
All right. Then you, as the social workers, connect with all these other resources in the community or with other health providers.
Exactly.
Okay. That's wonderful. One other question. On your slide about the different, your aging service experts, you mentioned something called ethnic resources that are available for private and or volunteer services. Can you give us some examples about what do you mean by ethnic resources?
depending on the community we're talking about, it varies. And so I kind of kept that term loose to tackle things like meals that are culturally sensitive. So for one of our bridge sites that works in a predominantly American immigrant area outside Chicago, they have a meal site that has food that's specific to culture. Supports that are tailored to be not only lingual but bicultural. Depending on the community, there's different needs. In my community, we had a need for an arthritis support exercise class. Maybe that's not ethnically specific, but it's unique to our area based on a specific need that we were finding in our community. So network providers do a map of their community to see what the unmet needs are and create services for that. And so getting to know the aging network in your community and know what unique services they provide, for example, for specific ethnic groups in your area can be helpful for somebody, especially as they're accepting a transition and starting to maybe contemplate assistance and support.
Okay. For the webinar is officially over. However, we're still recording, and so I'm wondering if you would be willing to take a few minutes to go back to the two slides that you skipped over because I sort of rushed you, slide number 28 and slide number 29, your figure there. And just for the purposes of people who are listening to the recording and I have a little bit more time, if you could kind of walk us through slide 28 and slide 29.
Sure, I'd be happy to.
Yeah, that's fine, and then the one right before that.
All right.
Okay, thank you so much. All right.
And so she did a really great job basically going over the process through her case example. And so what we'll do is backtrack a little and talk more about the details using this visual as to how Bridge works. He takes somebody who's been in the hospital and is now in rehab. So we'll work from left to right. So the person is, patient discharging from the hospital. They were seen at the hospital, typically a representative from the skilled nursing facility. They're seen by the Bridge Care Coordinator, and so we use ACC as an example from my site. But what happens sometimes, and we use Debbie's site as an example for a general review of the medical record and connecting with the partners in the hospital to get a thorough understanding of that patient's and situation prior to hospital discharges is important before that person leaves. So that little image on the left is kind of capturing what gets done before the person comes to the nursing home. The arrow is kind of sweeping through, and that basically is going to signify a continuation of information sharing and coordination during the transition. So information being shared to that nursing home, to that transitional point, and there's client history, hospital fate, assessment information. It's all with the nursing home transitional care team or whoever the point person is at that nursing home if a transitional care team hasn't been created yet at that site. When the person comes to the nursing home, the idea of Bridge is that all hospital information makes it there safely and is in the proper hands with the provider.
Add that experience program, other social workers in nursing homes experienced this before. The social workers I've been working with said they didn't get any social background on them before. I mean, they got very peripheral information about the medical history, and that was about it. So they really, really appreciated getting a biopsychosocial assessment and getting some of that information. So that's the feedback I've gotten social workers.
And so from there, one persons at the nursing home, the bridge assessment is started. And so we talked about this visual slide showing the basic process. So we continue the assessment by the bridge care coordinator, which is this social work assessment looking at the social determinants as well as the health history. Is contacted and assessed as well. We see a large volume of caregivers in need of being a part of this process to ensure that the care that they are providing and the support that is there so that our patients are safe and stable in their hands. Follow up with the team and referral to the nursing home services and start following up with community resources that are being identified as being for that patient when they return home. We're meeting with the interdisciplinary team at the nursing home. So again, we're collaborating and sharing our piece of what we've been talking to the patient and the caregiver about in terms of securing the community support. Plug that into what's existing in the walls of the nursing home. And so plug in information and learning from the interdisciplinary team about what we need to do for this patient to develop a transition plan that addresses care needs, home care and home health needs, mental health, medications, the list continues. But again, we can make the community-based services more concrete and expedite the time it takes to get those in place upon discharge by the table and part of the team. And so the unique role we have as a social worker doing bridge that complements well the work that the discharge planners or the social workers at the nursing home are doing, as well as the hospital. So person discharging from the SNFs, from rehab, and they go home with this transitional care plan, which is to the best of our ability, what we see should help them succeed with being stabilizing at home. Our plan with the client pre-discharge, and this can also be flexible. So let's say you already have implemented in your nursing home that a particular employee does that instead. That's fine, but just make sure that the care plan has been discussed pre-discharge. The nursing home typically sets up their specific services post-discharge per their requirements. And at the same time, what the bridge care coordinator is doing is arranging for those public or community services if needed. And so, we're working together as a team to take care of the range of services for that position. Carried over, and at 2 days post-discharge, we're continuing this assessment. So the best of what we, along with our patient and caregiver and the nursing home team, for as instability at home. But as we've seen, it's about 78% of people discharging experience surprises or new needs once they get home. So that darn step getting into the shower that they just didn't remember was there. So this assessment, we're completing it telephonically with the client or caregiver, depending on, if the client is able to speak for themselves at this time, we'll speak with the caregiver, provided their consent. We follow up with the transitional care team. Deb mentioned there's so much value for folks in the nursing home or the hospital to hear back on what's working for their clients, and follow up with them and let them know what happened. We'll spoke with them at home. And additional referrals, either services that the SNF can provide or community resources as needed. Additional follow-up with the home health agency or, wellness programs that some SNFs provide, things like that. 2 weeks post-discharge, and this doesn't happen everywhere, but this is an option. And again, it just is reinforcing our partnership and our interest in keeping the information going and checking in on that patient at their home. So we just go back and reassess. Typically, the telephonic intervention lasts 2 weeks anyways.
Yeah.
We find a transitional care team and provide, again, additional referrals as needed. Our goal is to, as soon as possible, get this person connected to the long-term supports that will keep them stable in place. But our aim is to make sure that at least by 30 days everything is in. But our focus is as soon as possible from that discharge. We have those supports in place. And then at 30 days, we're doing another check-in, as we discussed, and make sure that everybody has those supports in place. It's working out okay, and we're terminating the case. Transitioned back into the community. They have the case manager, for example, that they know who to contact, or they have access to that nurse through the primary care physician's office who will help them with the medical needs. They have their support groups, things like that. And the case is closed, and hopefully, hopefully see them again transitioning through.
Yeah.
So through with a bit of a visual, our process.
Thank you so much for making the time to prepare this presentation and then also to deliver it. And I also want to make one observation. You were talking about how important it is to the other health providers to know, well, what happened to this family through the system. But I also think that what you're doing is so valuable to the family and to the patient, because you're able to give them some feedback and to validate what they're doing and what they're attempting to do. And often our families don't get to hear that,
Mm-hmm.
And so even as you went through the case example, it was clear that you were helping son realize that this is what he's trying to do is big, and and that it's a sometimes people are going to need help, and it's okay for help, and then sometimes even how to ask for help, because if people have a lifelong pattern of not building and seeking skills, it's a lot to learn in a short amount of time.
In healthcare, there's so much focusation and clinically what is the need of the patient. The caregiver is often what we call the hidden patient.
Yeah.
People are not asking them, how are you, what do you need? So we have learned that to do that, and we've really gotten, I think, a lot of positive feedback and response, and just a great amount of need of caregivers. So we try to get all those systems as best we can. Intervention.
That's wonderful. It's a impressive program, I must say, and I really like the way that you explained what it looked like at an individual's level. What happened at one situation. You walked us through the case, but I'm impressed, and good luck with continuing this ambitious project, and thank you for sharing your expertise with the people online.
Thanks for having us. Bye-bye.
All right.